All right, let's get straight into it today. Cleft lip.
A very important topic for the FRCS plastic surgery exam.
Yeah,
We're
absolutely.
going to cover all the essential points.
Really hit those high-yield areas that you need to know for the exam.
Yeah.
So let's start with
We'll start with demographics.
the demographics.
And it's really important to remember the racial variations in the frequency. So Asians have the highest incidence at about 2 per 1,000 births.
Okay.
Caucasians are kind of in the middle at about 1 per 1,000.
Yeah.
And Black populations have the lowest incidence at about 0.5 per 1,000.
Got it. Now, in terms of the genders?
Gender distribution.
Yeah.
There's a male predominance.
Okay.
About a 2.1 ratio.
All right.
And the most common that you'll see is a left unilateral cleft lip and palate.
Okay.
It's also really important to remember that about 10% of infants with a cleft lip and palate will have an associated syndrome.
Okay, so we've covered who it affects.
Yeah.
Let's now look at how it develops.
Exactly.
Embryology
is a favorite of the examiners.
Oh,
So
yeah.
you got to know this stuff.
for sure.
So there are 5 prominences that are key to facial formation.
Okay.
The frontonasal prominence.
Yeah.
And then you've got paired maxillary and mandibular prominences.
Right.
So lip formation occurs between weeks 4 and 7 of gestation.
Right.
And a cleft lip occurs when the medial nasal process fails to fuse with the maxillary process.
Okay, so moving on then to the anatomy of a normal upper lip.
Okay.
What are the key landmarks that we need to know for the exam?
So you've got to remember your philtral columns,
Yeah.
those vertical ridges
Yep.
that define the philtrum.
Yep.
They're formed by the insertion of orbicularis oris muscle fibers into the skin.
Okay.
And in between these columns, you have what we call the philtral dimple,
Yeah.
which is a subtle depression
Okay.
where the muscle fibers are less prominent.
Got it. And then we've got the white roll,
The white roll.
that ridge above the vermilion border,
Exact.
the red part of the lip.
Yeah, so the vermilion itself has 2 parts.
Okay.
You've got the dry keratinized portion
Yeah.
and the wet non-keratinized portion.
Uh,
And it's widest at the peaks of Cupid's bow.
peaks at Cupid's bow.
Yeah.
And then we've got the tubercle.
Tubercle at the
Yeah.
base of Cupid's bow.
Yes.
Absolutely. So then in terms of muscles,
Muscles.
orbicularis oris is king.
Orbicularis.
Oris.
Yeah.
It has a deep and a superficial portion.
Okay.
So the deep portion is a sphincter.
Yeah.
And it lies beneath the vermilion.
Okay.
And then you've got the superficial portion,
Yeah.
which is involved in speech and facial expression.
Okay. And another muscle, the levator labii superioris,
Levat or labia superioris.
creates those peaks of Cupid's bow.
Yeah, helps to lift the upper lip.
Lift the upper lip. So just a very quick recap on the anatomy.
Yeah.
Blood supply from the superior labial arteries.
Yep.
Sensory innervation is the trigeminal nerve V2,
Correct.
and motor is the facial nerve.
Sedentized.
Okay, so now let's talk about the anatomy of a cleft lip itself.
Okay.
And it's important to say that the severity can vary quite widely.
Yeah, absolutely.
So even a subtle notch in the vermilion could suggest an incomplete cleft.
Yeah, definitely.
So really looking carefully is important
Absolutely.
when examining these patients.
Yeah.
So in a cleft lip, the premaxilla protrudes and rotates outwards, while the lateral maxillary segment sits further back.
further back.
And you'll also see abnormal insertion of the orbicularis oris
You will.
into the alar wing of the nose.
Exactly.
Okay, and then there's also hypoplasia of the pars marginalis,
Pars marginalis.
which is a specific part of the orbicularis oris.
Yep.
And the philtrum is typically shorter.
Shorter.
Now, bilateral clefts
Bilateral cleft.
present their own unique challenges.
They do.
They've got 2 deep clefts that separate the prolabia, the middle part of the lip,
Yeah.
from the lateral lip elements.
Oh.
And the prolabium lacks the typical structures,
It does.
like Cupid's bow,
Yeah.
the philtrum,
Yeah.
and philtral columns,
Yeah.
and it lacks orbicularis
Yeah.
oris.
Exactly.
Another thing to remember is Simonar's band.
Simonart's band.
That's right. Which is that residual skin bridge that
Yeah.
you sometimes see spanning the upper portion of the cleft lip.
That's right. Now let's talk about the nasal deformities
The nasal deformity.
associated with cleft lip.
Yeah.
These are very common,
Uh-huh.
and there are many different features
Okay.
that you can see.
So, for example, exam questions could focus on the underdeveloped lower lateral
Yeah.
cartilage,
Yeah.
asymmetrical nostrils,
Yeah.
or the deviated septum,
Aviated septum.
which often deviates towards the non-cleft side.
Yeah, exactly.
The alar base on the cleft side is displaced laterally, posteriorly,
Yeah.
and sometimes inferiorly.
And the inferior turbinate on that cleft side can be hypertrophic.
Okay. What about the columella?
the column out, tends to be shorter on the cleft side.
Okay.
And you can also get a deficiency of the vestibular lining
Yeah.
within the nostril on the cleft side.
On the cleft side.
Yeah.
Okay, great. So let's move on now to the etiology.
Etiology.
What causes this?
So there's no single gene
Right.
responsible for cleft lip.
Okay.
It's multifactorial.
Multifactorial.
With both genetic and environmental factors.
It's important to say that isolated cleft palate has a distinct genetic basis.
It does.
From cleft lip, with or without cleft palate.
Exactly.
And a positive family history significantly increases the risk of recurrence.
Yes, it does.
So if a parent has a cleft lip and palate, their child has a 3–5% chance of being affected.
Yeah.
Maternal age also plays a role.
It does.
With a higher incidence in mothers younger than 20
Yes.
or older than 39.
Yeah, that's right.
What about environmental factors then?
Environmental factors.
Yeah.
So exposure to certain medications in pregnancy, like phenytoin, can drastically increase the risks. It's been linked to a 10-fold increase in cleft formation.
Wow. Smoking during pregnancy.
Smoking during pregnancy.
Particularly in the first trimester.
Particularly the first trimester.
Another risk factor.
Absolutely.
But adequate folic acid.
Folic acid.
Can have a protective effect.
It can.
Okay, great.
Yeah.
So let's talk about evaluation and treatment.
Okay.
Of cleft lip.
So the most important thing to remember is a multidisciplinary approach.
Multidisciplinary.
Yeah.
So who's in the team?
So you're going to have plastic surgeons, otolaryngologists, pediatricians,
right,
speech and language therapists,
yep,
audiologists, geneticists, neurosurgeons.
Wow, okay.
And dentists.
And dentists.
Yeah.
Big team.
Big team.
Okay, before we talk about treatment, let's just touch on the classification system.
Classification system.
So clefts can be unilateral,
unilateral,
bilateral,
complete or incomplete.
Complete or incomplete.
So a complete cleft.
Complete cleft.
Extends through the entire lip.
Into the floor of the nose.
Into the floor of the nose.
Whereas an incomplete cleft spares the nasal sill.
Spares the nasal sill.
And then we've got microform clefts.
Microform clefts.
Which are the mildest form.
The mildest form.
Maybe with a small notch in the vermilion.
Yep.
Or subtle alar deformity.
Subtle alar deformity. It's important to address feeding challenges early on.
Yeah, especially in infants with a cleft palate.
Yeah.
So you can use specialized nipples.
You can.
Like the Haberman.
The Haberman.
Or squeezable cleft palate nursers.
Squeezable cleft palate nursers.
Okay, so now let's talk about treatment options.
Treatment options.
Starting with intrarotarin repair.
Intrarotarin repair.
Which is where you surgically correct the cleft while the baby is still in the womb.
Yeah, so this is still considered experimental.
Experimental.
Yeah.
Right.
And it carries significant risks.
Right.
Primarily of preterm labor.
Preterm labor.
So for that reason, it remains a topic of ongoing research.
Okay, nasal valvular molding is a more established approach.
It is.
And this aims to improve alveolar segment alignment.
Yeah.
And reshape nasal cartilages before surgery.
That's right.
So this can involve active appliances.
Active appliances?
Like the Latham device.
Latham device.
Or passive appliances.
Like passive appliances.
Like molding plates.
Molding plates.
Another procedure is lip adhesion.
Lip adhesion.
Where you create a temporary closure of the lip.
Yeah.
To encourage maxillary segments to move closer.
Move closer.
So you're effectively converting a complete cleft into an incomplete cleft.
That's right.
So it's beneficial for wide, complete unilateral clefts.
Yeah.
And cases where the maxillary segments are poorly aligned.
Exactly.
Because it reduces the severity of the lip and nasal deformity.
It does. Moving on to gingivoperiostoplasty.
Gingivoperiostoplasty.
He's shown focuses on the gum and bone around the cleft.
Okay.
And it aims to eliminate nasal velar fistulas. And provide support for the alar base.
The alar base. Okay. So studies suggest up to 60% of patients who underwent nasal velar molding and gingivoperiostoplasty did not need a secondary bone graft later on.
That's right.
Okay. Let's now talk about the methods for unilateral cleft lip repair.
Methods for unilateral cleft lip repair.
So we've got the Rose-Thompson straight line repair.
Rose-Thompson straight line repair.
Which is suitable for microform clefts and vermilion notching correction.
Correct.
Triangular flap repairs.
Triangular flap repairs.
Like the Tennyson and Randall techniques.
Yep.
Use a single Z-plasty at the vermilion skin junction.
Quadrangular flap repairs, like the Hagedorn and Lemessurier techniques, employ a different flap design.
Okay.
But the most commonly used is the Millard rotation advancement technique.
The Millard.
Millard.
So tell me about the Millard.
So the Millard technique involves rotating the medial lip element downwards.
Okay.
And filling the resulting defect with tissue from the lateral lip.
Okay.
And the scar is placed along the natural line of the philtral column.
Okay, before we go into the specifics of the Millard repair, let's just break down how you mark a unilateral cleft lip for surgery.
Okay.
So using methylene blue dye.
Methylene blue dye.
You mark the key landmarks.
Key landmarks.
So first, you identify the peak of Cupid's bow on the non-cleft side.
Non-cleft side.
Then you mark the low point of Cupid's bow and the proposed peak on the cleft side.
That's right.
Then you mark the midpoint of the columella.
Midpoint of the columella.
And its lateral bases. Along with the inset of the ular base.
The ular base.
And then finally you mark the proposed peak of Cupid's bow on the lateral lip element. And the low point of Cupid's bow on that side.
Okay.
Great. So now let's go step by step.
Okay.
Through the Millard rotation advancement repair.
Okay.
So the cutaneous incisions are made along the lines of the rotation and advancement flaps. Using a fine surgical blade.
Fine surgical blade.
Mucosal incisions are made with a number 11 blade.
Number 11 blade.
Staying within the submucosal plane.
Submucosal plane.
Tell me about the different flaps involved in this repair.
Okay, so the C-flap.
C-flap.
Which stands for columellar flap.
Columellar flap.
Is a triangular piece of skin that starts at the high point of Cupid's bow.
Okay.
And it can be used to close the nasal sill or lengthen the columella.
The columella.
The M-flap,
M-flap,
which stands for mucosa or medial, is a rectangular flap of mucosal tissue from the medial lip element. And this is used to line the gingiva-buccal sulcus.
The gingiva-buccal sulcus.
And lastly, the L-flap,
L-flap,
which stands for lateral, is a superiorly based flap of mucosa from the lateral lip element. And this is used to line the lateral nasal vestibule.
Okay, so once the flaps are outlined, the skin and the mucosa are carefully lifted.
Lifted
off the underlying orbicularis oris muscle.
That's right.
And then you release the muscle from its abnormal attachment.
Abnormal attachment.
To the nose.
Yeah.
Columella.
Columella.
Nasal sill.
Nasal sill.
And alar base.
Alar base.
Okay. And the gingival-buccal sulcus is also incised on both sides.
It is.
To further free up the soft tissues.
Free up those soft tissues.
Okay. And then careful dissection is performed over the lower lateral cartilages. Nasal tips. And onto the nasal dorsum.
That's right.
So then next comes the nasal reconstruction.
Nasal reconstruction.
Which is often incorporated into the primary lip repair. So sutures are placed from one alar base to the other.
From one alar base to the other.
To reshape and reposition the nostrils.
That's right.
Okay. And then closure begins with the internal structures.
The internal structures.
And then moves to the more superficial ones.
Superficial ones.
So the L-flap is sutured into the defect in the lateral wall of the nasal vestibule.
Correct.
Then the lateral gingivobuccal sulcus is closed.
Closed.
Followed by the medial sulcus.
The medial sulcus.
Using the M-flap.
Using the M-flap.
And then the orbicularis oris muscle is brought together and sutured.
Sutured.
With absorbable suture.
It's absorbable suture.
And then the lip is closed.
The lip is closed.
Bringing the rotation flap down. And advancing the advancement flap medially. And then the superior defect, if present, is closed using the C-flap.
The C-flap.
And in some cases, a Nordhoff flap might be used.
A Nordhoff flap.
To add bulk and improve the lip contour.
Improve that lip contour.
Okay, so let's now talk about primary cleft rhinoplasty techniques.
Primary cleft rhinoplasty techniques.
Which aim to correct the nasal deformities. So pre-surgical maxillary orthopedic devices? Like molding plates?
Like molding plates?
Can be helpful in molding the nasal cartilages? During the cleft lip repair? Complete release of the nasal ala from its abnormal attachments is really important.
Really important.
And the distal midvault and tip of the nose are then widely dissected. Allowing for
reshaping.
So sutures are placed from the lateral alar base to the opposite, more stable foot plate of the medial crust of the lower lateral cartilage.
So you're reshaping the nostril and lifting the alar rim.
Okay. Mattress sutures are often employed to correct alar webbing.
They are.
And there are two specific techniques that are commonly used.
Yeah.
The Tajima suture.
It's Tajima suture.
And the Macomb suture.
And Macomb suture.
So the Tajima suture involves an infracartilaginous inverted U incision on the cleft side.
That's right.
And the suture is passed through the caudal portion of the lower lateral cartilage on the cleft side. And then through the contralateral upper lateral cartilage.
Yeah, so this supports the lower lateral cartilage on the cleft side.
Yeah.
Improving nostril shape and position.
Improving nostril shape and position. Yep. Okay. And then the Macomb suture is placed from the skin through the middle genu of the lower lateral cartilage.
Yeah.
On the cleft side.
Lungs left side.
And tied over a bolster.
Yep.
Which lifts and rotates the alar rim.
The alar rim.
So let's move on now to bilateral cleft lip repair.
Okay.
So the philtral flap plays a really crucial role here.
It does.
As it will be used to create the central portion of the lip.
Yep.
Including the philtrum and Cupid's bow.
Yeah.
So the philtral flap, typically 3 to 4 millimeter wide.
3 to 4 millimeter wide.
Between the peaks of Cupid's bow.
Cupid's bow.
Is meticulously marked and created from the central skin of the prolabium.
Exactly.
So there are two main approaches that are used.
Two main approaches.
The Millard and the modified Manchester repairs.
Yep.
They differ in how they reconstruct the vermilion.
Yeah.
And manage the prolabium.
The prolabium.
So in the Millard repair, Cupid's bow and the central tubercle.
Cupid's bow and the central tubercle.
Are created from the white rule and vermilion tissue.
That's right.
Of the lateral lip segments.
Yep. Okay.
And the modified Manchester repair uses tissue from the prolabium itself.
From the prolabium itself.
So let's outline the steps involved in a typical bilateral cleft lip repair.
Yeah.
So first, you mark the proposed points for the peaks of Cupid's bow.
Yeah.
And the line where the vermilion meets the skin on the lateral lip elements.
That's right.
And then the philtral flap is incised.
Incised.
The lateral skin is deepithelialized.
Deepithelialized.
And the remaining prolabial skin is discarded.
Discarded.
So in the Millard technique,
yeah,
forked flaps from the prolabium may be banked.
Yeah.
Potential columellar lengthening procedures.
Yep.
Later on.
Then
the lateral white line vermilion flaps.
Okay.
Which will create the sides of Cupid's bow.
The sides of Cupid's bow.
Are incised.
Yeah.
And the alar base flaps are elevated.
The alar base flaps are elevated.
And the orbicularis oris muscle is carefully dissected.
Dissected.
From the lateral lip element.
Lateral lip elements.
And the nasal floor is reconstructed.
Reconstructed.
Using bilateral mucosal flaps.
Bilateral mucosal flaps.
And the orbicularis oris muscle is then meticulously closed, followed by insetting the philtral flap.
A philtral flap.
To create the central portion of the lip.
That central portion of the lip.
Okay, so finally then, let's discuss postoperative care.
Postoperative care.
So immediate postoperative feeding is generally allowed.
It is.
And the wound is cleansed with a diluted hydrogen peroxide solution.
Diluted hydrogen peroxide solution.
Arm restraints are typically unnecessary.
They are unnecessary.
And silicone gel sheeting.
Silicone gel sheeting.
Can be applied to the incision line.
Yeah.
After about a week.
About a week.
To minimize scarring.
Minimize scarring.
Okay, let's now talk about some potential complications.
Okay.
So one is the whistling deformity.
The whistling deformity.
Which is a central vermilion deformity.
Yeah.
More common after bilateral cleft lip repair.
More common after bilateral cleft lip repair.
So it presents as a notching?
Yeah.
Or inadequate vermilion.
Yep.
Exposing the central incisor teeth at rest.
So a VY advancement procedure can be used.
VY advancement.
If there's excess vermilion tissue.
Excess vermilion tissue.
But in severe cases, an Abbey flap might be necessary.
An Abbey flap?
Yeah.
Another complication is a short lip.
A short lip.
More frequent after the Millard repair.
The Millard repair.
So this can be corrected with a re-rotation and advancement procedure.
Yeah.
Or a VY advancement technique.
VY advancement technique.
Conversely, a long lip. Is
Yep.
more common after Le Mergeret or triangular flap repairs.
That's right.
And that would require a full thickness tissue excision below the nostril sill.
Below the nostril sill.
A widened lip scar can indicate inadequate orbicularis, oris muzzle continuity.
It can.
And may require revision surgery.
Revision surgery.
And finally, lip landmark abnormalities.
Lip landmark abnormalities like asymmetry or displacement of Cupid's bow can occur.
And these can often be corrected with elliptical excisions or Z-plasty techniques.
Z-plasty techniques.
So we've covered a lot of ground there.
We have.
But this in-depth look at cleft lip and its management is essential.
It is.
For the FRCS exam. So make sure you review those key figures and tables from your textbooks.
Yeah.
Because the details really matter.
They do.
Especially on exam day.
On exam day.
Let's go over some of those key takeaways about cleft lip that you really need to know for the FRCS exam.
All right.
So firstly, remember that the incidence of cleft lip and palate varies by race.
Yeah.
But isolated cleft palate does not.
That's right.
So what's the best approach to evaluating a patient with a cleft lip?
Okay, so first of all, meticulously describe the defect and determine if there are any other associated anomalies.
Okay.
And then involve all the appropriate specialists to help you with your assessment.
Okay. And I imagine presurgical management is important as well.
It is.
Yeah.
Presurgical nasal valvular molding can really significantly improve the outcome of your primary repair.
Yeah.
And this is true for the lip and the nose.
And how does that impact on how you approach the surgery?
Well, primary cleft nasal repair is often incorporated into the primary lip repair.
Okay. To address those nasal deformities at the same time. So essentially, a really good, meticulous primary repair.
Primary repair is the best way to prevent those secondary deformities.
Exactly, yeah. And when secondary deformities arise, when is the best time to address those?
So ideally, you want to address those after facial growth is complete so that you can get the best long-term results.
Makes sense.
Yeah.
Now let's talk a bit more about the techniques for bilateral cleft lip repair.
Okay.
You mentioned the Millard and the modified Manchester repairs.
Yeah.
Can you just delve a bit deeper into the differences between those?
Sure. So the Millard repair constructs Cupid's bow and the central tubercle using tissue from the white roll and the vermilion of the lateral lip segments.
Okay.
Whereas the modified Manchester repair uses tissue from the prolabium itself for this reconstruction.
Okay, so they've both got their advantages and disadvantages then.
They do. And the choice really often depends on the surgeon's preference.
Okay.
And the specific anatomy of the cleft.
Could you elaborate a little bit more on those advantages and disadvantages?
Yeah, so the Millard repair is known for its versatility.
Okay.
And ability to create a more natural-looking Cupid's bow. However, it can be a bit more technically challenging, particularly in wide clefts.
Okay.
And it can sometimes lead to a short lip.
All right. And the modified Manchester repair?
The modified Manchester repair is simpler to perform, but may not achieve the same aesthetic result.
Okay.
Particularly in terms of that Cupid's bow definition.
So really the choice comes down to, carefully looking at the patient's individual anatomy.
Absolutely.
And weighing up those pros and cons of each approach.
Yeah. So you need to weigh the complexity of the repair against the desired aesthetic outcome and the potential for long-term complications.
What are some specific things you'd be thinking about when you're choosing between these repairs?
So for instance, in cases of a wide cleft, you might prefer the Millard repair.
Okay.
Because it provides more tissue for reconstruction.
Right.
But conversely, in a narrow cleft, the modified Manchester repair might be a simpler and more effective option.
Got it.
Yeah.
And how do these techniques address the prolabium?
The prolabium.
Which we said can lack those typical anatomical structures.
So in the Millard technique, the prolabium is often used to create the philtral dimple and lengthen the columella.
Right.
And the lateral lip elements contribute to forming Cupid's bow.
Right.
But in the modified Manchester repair, the prolabium itself is used to construct Cupid's bow.
Okay.
And the lateral lip elements are mainly used to just close the cleft.
So really, it sounds like a really thorough understanding of the anatomy.
Absolutely.
Meticulous surgical technique is needed for both.
You need a thorough knowledge of facial anatomy.
Yeah.
Careful planning and meticulous execution to get the best results.
Okay, great. So moving beyond the techniques then.
Okay.
What about postoperative care for bilateral cleft lip repair?
Postoperative care.
Yeah. Are there any specific considerations compared to unilateral repair?
So postoperative care for bilateral cleft lip repair is very similar to unilateral repair.
Okay.
But there are a few differences.
Like what?
So because of the wider extent of the surgical site, there's a greater need for meticulous wound care to prevent infection and ensure good healing.
What about feeding?
Feeding.
Is there any difference in approach there?
So similar to unilateral repairs, immediate postoperative feeding is generally encouraged, but you need to pay particular attention to make sure the infant can achieve adequate suction and maintain proper nutrition.
Okay. And arm restraints and silicone gel sheeting.
So arm restraints are typically unnecessary. And silicone gel sheeting can be applied to the incision lines after about a week to help minimize scarring.
Okay.
And this is usually continued for 6 to 8 weeks.
Okay. Are there any complications that are more common with bilateral cleft lip repair?
So the whistling deformity?
The whistling deformity, which we discussed earlier, is more frequently seen after a bilateral repair.
It is.
And how do we manage that?
So management depends on the severity. So in mild cases, a VY advancement procedure can be used. But for more severe cases, you might need an Abbey flap.
An Abbey flap, okay.
Which borrows tissue from the lower lip.
Okay, great. Now, another potential complication, a short lip.
A short lip
is more common after
the Millard repair.
The Millard repair.
Yeah.
Okay.
And that's regardless of whether it's a unilateral or bilateral repair. And how do we address that then?
So a short lip can be corrected with a re-rotation and advancement procedure or a VY advancement technique. Borrowing tissue from the nostril cell to increase lip length. And conversely, a long lip.
A long lip,
though less common, can occur after Le Majorier or triangular flap repairs.
Yeah, and in these cases, you need a full-thickness tissue excision below the nostril cell to shorten that lip and achieve a more balanced appearance.
Okay, and another one to watch out for, a widened lip scar.
A widened lip scar can be a sign of inadequate orbicularis horis muscle continuity.
Okay.
And might need revision surgery.
To improve both the appearance and function of
Exactly.
And finally, lip landmark abnormalities.
Lip landmark abnormalities can include things like asymmetry or displacement of Cupid's bow or the philtral column.
And these often require...
They often require techniques such as elliptical excisions or Z-plasties to just refine that contour of the lip.
Okay, so these complications really highlight the importance of the meticulous surgical technique.
Absolutely.
And the need for long-term follow-up.
Long-term follow-up is essential
to manage any issues that arise.
Cleft lip and palate repair is a complex and nuanced field. Requires surgeons to be well-versed in a variety of techniques and to be prepared to address that range of potential complications.
Yeah, absolutely.
Yeah.
So this brings us to the end of our deep dive on cleft lip.
Okay.
Hopefully this rapid review has been beneficial for your exam preparation.
Yeah.
Remember, strong foundation in those basics, coupled with a good understanding of those various surgical techniques and complications is really crucial for doing well in the FRCS exam.
Yeah, absolutely.
So we've covered a lot of information today.
Yeah.
Demographics, embryology, anatomy, the ins and outs of cleft lip repair.
All those little intricacies.
It's been a deep dive.
It has a lot to take in.
It is, but it's all necessary.
It's all really important.
For exam success.
And don't underestimate those seemingly small points.
Yeah, absolutely.
Because they could be the key to unlocking those tricky MCQ questions.
Yeah, the examiners love to test you on those fine details.
They do.
So what are your final recommendations for students prepping for the FRCS exam?
Yeah.
Specifically on cleft lip.
So focus on understanding the principles behind each surgical technique.
Okay.
Don't just try and memorize the steps. Try and visualize the anatomy. And really understand why certain decisions are made.
Understand the why behind the how.
Exactly.
Yeah, that's crucial for those applied clinical scenarios that come up in the exam.
Absolutely.
Okay, good.
And don't forget to pay attention to those key figures and tables in your textbooks.
Yeah, they can be really helpful.
They can.
Those visual aids.
Visual aids are very important.
Especially for those complex procedures.
Yeah.
Like the Millard repair.
Absolutely.
Okay, great. And lastly, practice, practice, practice.
Yeah.
Whether that's mock exams, case discussions, or surgical simulations.
Yeah. Actively engaging with the material will really make all the difference.
On the day.
On the day.
That's a great point to end on.
Yeah.
So best of luck with your studies.
Good luck.
And remember, thorough preparation breeds confidence.
It does.